It's important to point out that there are two oral agents that are available for patients who have refractory disease. There's trifluridine plus tipiracil, and there's regorafenib. Whenever I'm considering which agent to use, again, I go back to important considerations that the patient may have. Both drugs have slightly different side effect profiles. Also, there are important considerations, again, about their comorbidities, their tolerance of prior therapy, their blood counts, for example, any lingering toxicity from previous drugs, such as diarrhea. In this patient, trifluridine plus tipiracil would be a very reasonable option for continuing use of a systemic chemotherapy. It's important to point out that the clinical trial that led to the approval of trifluridine plus tipiracil was a randomization against placebo plus best supportive care. In this trial, patients were treated until they had progressive disease or had intolerance to therapy. Therefore, I always tell my patients who are going to start on this therapy that we're going to use it as long as it's helping them. So as long as the disease isn't progressing and they're tolerating the therapy well, we'll continue it. In the randomized clinical trial compared to placebo, there was a better progression-free and overall survival for the use of trifluridine plus tipiracil. As part of the counseling for administration of trifluridine plus tipiracil, we always warn patients about some of the side effects. The most important one is the development of neutropenia, and there were patients who developed neutropenic fever as well on the randomized clinical trial. Now, there can certainly be other side effects such as diarrhea and fatigue and occasionally oral lesions. But the critical one that they need to let us know about is if they're developing any fevers. We also do check white blood cell count during a cycle to inform whether a person is actually developing neutropenia. Furthermore, it's critical that patients have a CBC performed prior to initiating a new cycle. If they have an ANC less than 1,500, they should not be treated until the ANC rises above 1,500. Similarly, if they have a platelet count less than 75,000, they should also be delayed until the platelet count exceeds that. Because neutropenia is quite common in patients receiving trifluridine plus tipiracil, we have found that it's very important to consider whether to dose delay or dose reduce. Currently, we recommend that if a patient has an ANC less than 1,500 on the day that they are to start a new cycle, that we delay another week and recheck their CBC. If their ANC is greater than 1,500 at that point, we recommend continuing the same dose of the trifluridine plus tipiracil as they received in the previous cycle. However, if the ANC continues to be less than 1,500 or they've had other toxicities that cause a longer delay, then it is recommended to reduce the dose prior to starting that next cycle once the ANC is greater than 1,500. There are other interventions one could consider for patients who do develop neutropenia while on trifluridine plus tipiracil. One of these is the use of G-CSF. Now, in the pivotal trial, only about 9% of patients did receive white cell growth factor support, but it certainly is acceptable to use it because there is a 14-day window from the time patients receive their last dose until they're likely to start a new cycle. There's quite a bit of interest in administering trifluridine plus tipiracil with other therapies. While this combination therapy is not the same as a fluoropyrimidine, you can imagine that in other areas where fluoropyrimidines have been administered, there's considerable interest in using trifluridine plus tipiracil. So for example, there's a clinical trial evaluating the use of maintenance therapy with trifluridine plus tipiracil plus bevacizumab. Because there's considerable interest in the use of immunotherapy in advanced colorectal cancer patients, there are also at least 2 clinical trials evaluating trifluridine plus tipiracil with nivolumab. And furthermore, there are clinical trials administering trifluridine plus tipiracil with other novel agents. For example, there's an anti-Notch1 antibody in development that is being studied in combination with trifluridine plus tipiracil. And of course, there are at least 2 clinical trials that include an arm where oxaliplatin is being used with trifluridine plus tipiracil as well. The unfortunate reality for most people with metastatic colorectal cancer is that they will progress through all the lines of therapy. However, I found that in patients who have received the oxaliplatin, irinotecan, fluorouracil, bevacizumab, and where appropriate anti-EGFR targeted therapy, and still have a reasonable performance status, that most patients do want to continue with some type of therapy to see if they can maximize survival. I've been very gratified to find that patients that I've administered trifluridine plus tipiracil to have tolerated it reasonably well. We, of course, do have to consider the neutropenia. It is very common that we do need to dose delay, but less frequently need to dose reduce. And we've been able to have patients maintain adequate quality of life throughout that therapy. And because it's known to have, on average, a survival benefit, we believe that we're giving those patients additional time for the things that are important to them. Also, I found that even at the point that they do progress, that they've generally maintained a reasonable performance status and quality of life, so they would be eligible for yet other therapies.